Hi, Jen.
Hi, Martha. How are you?
I'm good.
Good. Thank you so much for your presentation. You were awesome. I've heard so much good feedback about you. So
Oh, thank you.
thank you. It was really good.
It was a lot of fun, though.
Well, good. So I have something very exciting happening next door. So I have to admit that I'm not going up into my regular room to hide because my neighbor's got a rescue horse and didn't know that she was pregnant. And she's
Oh,
this afternoon in the field, like right next to my yard.
so
And
she's delivering. Oh my
she's gonna
goodness.
live within like the next 2 hours. So I've got to watch it because I've never seen a horse being
Yeah,
born.
yeah, yeah.
So I'm like, normally I take my computer and go to my upstairs office where it's quiet. And I'm like, I can't because I can't look out the window and I have to be able to see it. So
Oh,
how exciting, huh?
I know.
She's laying in the field making weird noises. The vet said for sure within like the next 2 hours.
It will happen. Oh gosh, I'm in pain already.
I know. I know.
Having flashbacks when I had my kids.
Well, and I always feel bad for like pregnant moms. I'm like, oh, just let it be painless and like
Yeah.
easy. And so like I just want her to have it and be over and the baby's healthy so I don't have to worry. But yeah, it's kind of exciting. So
Oh, right.
but I get
Do you mind if I share really quick my?
oh right ahead.
I want to make sure I'm doing the right thing. Can you see it? Awesome.
It's not on the it's not
Oh,
on
it's not on
slide.
that. Yeah, let's do this. And you tell me. What about now?
Perfect. Perfect.
Perfect. Okay.
Right. Good. How are
I
things otherwise? You good?
good. Enjoying the weather.
I know, me
It's
too. Finally
warm.
summer, right? Finally.
It's
Took a
warm.
while.
Yeah.
Yeah, took a
Yeah.
minute, but it's good. I'm really excited about it too. People
Okay.
are like, it's too hot. I'm like, oh,
Nope.
stop.
It's
Nope,
ready. It's
I'm
great for
taking
me.
it. Yeah, I'm with you. I'm like, I'm fine. No
Yep.
way.
I'm definitely a very like I love warm and the warm. I mean, it cannot get too warm for me. It's just no.
I'm with you. I'm gonna go lock up the dog so I can sit here.
Sure.
Hello? Yeah, this is Martha.
Are you all set, Martha?
Sorry, yeah, I needed
That's
to
okay.
get a phone call, but I'm all ready.
You're ready whenever they jump on. Okay, you can just kick it off today. I'll welcome everybody and then we'll
Great.
start with you. All right, good. People are really excited about it. Ann Take is already looking to set up another session with you guys. She met with Neftali earlier this week. It was really good.
Oh, yeah.
Yeah.
Yeah, I couldn't be in that one, but I'm following up with her with some of the questions in her meeting. Actually, do I need to copy you in those emails, right?
If you would, that would be great. Then I can just kind of keep track of what's happening. Yeah, and she's setting up a time with you to talk about doing the PIP.
Yeah, so I'm gonna just actually right now forward the
Okay.
last email I sent to her
Sure.
today.
Perfect.
So you know what's going on there.
Perfect. Thank you.
I need to get into the habit of always.
Yeah, no worries. No worries. Hello. Welcome. We're just going to wait for everybody to join and then we're going to get started today. There might be a baby horse born next door to my farm in the middle of your meeting. And if so, I'm going to take the computer outside at the end and show everybody pictures of a baby.
And I kept thinking, I know they have it.
Hello, everybody. We're just going to wait for a couple more minutes for everybody to get here and we will get started today. Thanks for joining us. We're going to wait for one more minute, you guys. We have a few people just continuing to log on and then we'll get going. Welcome everybody to the 5th installment of integrated behavioral health training with Martha and Naftali. And I'm going to fill everybody in that my neighbors rescued a horse and didn't know she was pregnant. So I keep looking out my window because she's having a baby in the field in front of my house right now. So I'm going to get to
That's
watch a baby
awesome.
while you guys are all talking integrated behavioral health, and I'm pretty excited about it. So
Can you turn your monitor when that happens so we can
Yeah.
all see?
if she has the baby before the end of the meeting, I promise to take my computer outside and let you guys all get a look at a brand new baby foal. So.
Cool.
All right, everybody. It looks like we've got most people logged on. Welcome, everybody, to the 5th installment of the Integrated Behavioral Health meeting with Martha and Naftali. I'm going to turn it right over to Martha, who's going to kick off our meeting and get us going today. If everybody can remember to mute, if you have questions, put them in the chat or unmute yourselves and ask. Feel free to ask questions. We're glad you're here. I'll turn it over to you, Martha.
Thank you, Jan. I feel we're already a family meeting once a month, everyone. But for those who it's the first time, my name is Marta Saucedo. I'm the project manager for technical assistant at CFHA, the Collaborative Family Healthcare Association. And I'm here today with Naftali Serrano, or Naftali Serrano, however you want to say it, who is our CEO today. And today we're going to be talking about a topic that a lot of people ask us about, and sometimes they struggle when they're actually, changing from specialty care to more integrated care, which is documentation. It takes time to get that just to documentation, but also one of the things that we hope that you gain today, it's just how to do documentation by checking all the boxes that it's required, but also be very effective with how you do documentation. And while I get ready setting the presentation, I'm going to turn it to Naftali just for him to say hello to everyone while I do all my clicks here.
Hey, everyone. It's great to see you all as well. Hopefully, you can focus in on our exciting conversation on documentation and not wonder too much about the horse being born outside the window. What a great way to join a webinar, right? Have a horse being born outside your window. That's fantastic. So we're excited to talk with you about this conversation. As Martha said, it's a conversation that's it's just one of those like nuts and bolts type things that is pretty important for a couple of reasons. One is you want to have good communication as a care team. You also want to have the ability to be able to pass an audit, right? And the other hidden thing and reason why we spend so much time about this is that good communication of this kind can be important for actually reinforcing the model of care that you're providing and selling that model of care to your primary care team. Whereas if you do documentation poorly, you can often really slow down the progress of your implementation, have providers who are just not bought into this work. So it may not sound like a very sexy topic, but it's a really important topic to discuss in your program development.
I also want to add that I sent to Jen, and I know she emailed to all of you, not just the PowerPoint, but 2 more other documents that are going to be helpful for all of you. One is actually an example of a template, and with all the drop downs. One of the things we want to highlight is that sometimes when you do have a template, it not just create a uniform way of your notes in your department, either if you're the only one there or you're creating integrated care model or whatever, or you have working with other people, but also it saves you a lot of time with all drop downs, right? And just having clue parts of the note in which you can actually write your impressions or whatever happened on the session. So that document is with you guys. If you don't have it, reach out to Jen. And then the second document, it's a PDF, which actually checks the boxes of what Neftali was saying, just having all the requirements that you need in a note. And please just guide me, because in my computer, it seems like you guys are, everybody seeing a page that says documentation. Is everybody seeing that? Okay, great.
We're good.
So let's move on.
Before we get started, Martha, I just wanted to clarify as well that when we talk about documentation today, most of the material is going to center on PCBH documentation or documentation for PCBH. And so what we're talking about here is a licensed mental health provider providing interventions in the PCBH model using either the psychiatric codes, the psychotherapy codes are called, or the health and behavior codes. Right, so that's most of what we're talking about. But as we go, I'll also make some commentary as we go around how some of this will adapt to the collaborative care model, which the documentation there is just a little bit different.
And also, if you're feeling lost on the billing codes, the next session next month, it's about billing. So we might not going to be into depth into those, because we're going to be talking more next month about it. Okay, so here we have it's actually how it will look to your note. If you can really see, it should not be more than one page. It's 4 sessions that we're going to be focusing, which is the assessment, the plan, subjective and objective, which we call it just the APSO note. It says, I don't see your screen. People are not seeing my screen.
I think. Does everybody else see the screen? Can everyone see the screen?
I can see your screen, Martha. I think it's
Okay.
Too. And you might be having some other issue. Maybe try logging on and off.
Okay.
Are others seeing the screen? Can people just type in the chat?
Yes, I can. Sandy.
Okay, thank you.
Perfect, thank you. And then what we're gonna do today, it's we're gonna start talking about each of these sections in more depth. But just visually, for those who are a very visual person like me, this is the way it should look. It's just like one page, very brief. And the ideal is that you can do this note in between 7 to 10 minutes. I'm gonna give that buffer of 3 more minutes, but usually you should be very effective writing a note in 7 minutes. Okay.
All right, so I'll start off by just talking about the first section. And just to clarify, in case I know there was a lot to see in that first visual, but that's obviously not a completed note. That is what the note template looks like.
Correct.
We typically recommend folks to use, and so you would be filling in information in those key areas, especially those starred areas, is where you'd end up. And the colons, after the colons, you'd end up filling information. Now, a lot of that, just as an FYI, if you look at Martha created a great document that you'll have, or maybe already have, with drop downs for each of these areas. So that's what it would look like in an EHR. So that's why you can write this note in about 7 to 10 minutes, because there's a lot of drop downs in there, and it's easy to navigate through the note. And we put the assessment at the very top on purpose. And that's important, because remember that a note sells your service. And this is true of PCBH note or a COCM note. You want the most important information at the top of your note, so that the provider, who doesn't have a lot of time to read, can see that information first. And so the assessment is important to the provider, right? That's why we put it up there, because it tells them, hey, this is what we think's happening, and this is what we think is going to help this patient do better, right? So regardless if you're doing PCBH or COCM, you want that assessment up front as to so that the provider understands, oh, okay, patient's improving, patient's not improving, etc. So we do a lot of teaching around the assessment in particular, because we want folks to be able to think critically about how they think and conceptualize cases, and then be able to communicate that to the provider through the note. So if you look here, we have this little sort of verbal equation. This is how we train our mental health providers to write an assessment. Patient with, so that could be depression, related to recent unemployment, job loss, in the context of a history of prior abuse or trauma. Patient will benefit from, and that could be, that's generally a target area, or patient will benefit from increasing their capacity for tolerating negative emotions, or patient will benefit from behavioral activation, right? And then patient in, and then whatever stage of change they're in. So some assessment of how ready they are for the change process. And so what you have in this assessment is hopefully a succinct understanding of what's happening with the patient and why it's happening, and the track that treatment should move forward. And so for example, if the patient would benefit from a combination of some sort of behavioral intervention and medication, the primary care provider is going to be able to see that right away, understand what's happening, and then hopefully act on that for their next visit.
I was just putting on the chat that we sometimes when we review notes, we do see that they have in the assessment just a diagnosis. So people have in their notes assessment, depression, or depression with anxiety. If you see here, it's different. It's more about your clinical impressions, nothing that the patients say to you, but it's more about how you're processing and how you're thinking the patient is coming with, and how can the patient will move forward, right? And when we think about moving forward, as it says on the title, functional assessment, think about how the patient will function better. So how I'm going to help this patient who has depression or anxiety to function better in their life. And that's what you're going to put in that paragraph.
And again, regardless of model, if you're working in COCM, you want your care manager to have the ability to think functionally, just like Martha just described, just in very much the same way that a BHC will think, and to be able to communicate effectively an assessment of where the patient is, so that they can provide that support to the provider. Let's say the care manager can make a follow-up phone call with may make a follow-up phone call with the patient on their registry, and they get some new information. They do an intervention over the phone. You want that communicated very, very clearly in the assessment, so the provider has a good sense and understanding of what to do and can make decisions, typically around like titrating medications, for example.
Do you want to talk about this slide, or should we go to the next one?
Yeah, I think this slide just really, this is more of something, so what you're seeing here, you should know, is a set of slides that we use for clinicians. We know that most of you, or many of you, are not necessarily clinicians, but we want you to see how we would train clinicians to be thinking about writing these assessments. And you can see this really highlights Martha's point that if you just put in your assessment the diagnosis, you haven't really done very much, and it's not very helpful, right? I mean, the physician and the care team already knows, the patient knows oftentimes what their diagnosis is. Yeah, I came in for depression. That's great. You haven't done anything for me, right? And the doctor might say, well, okay, great. So I knew they were depressed. That's your assessment? I mean, like, where do we go from here? What do they need? What's going to be helpful, right? And so that's what this says is, hey, you should be thinking very critically about what's really going on with the patient, and look at those underlying causes, that first level cause area, and then down, when you get down into the root cause, we're really looking at, hey, where can we actually make some progress here? Where are we going to actually really help this patient improve? That's where we tell our mental health professionals in integrated care, that's where you make your money, when you're able to help the care team understand what direction to take with the care of that patient and their behavioral health issue.
If you really think about, like, I remember, and I don't know if it happens for you clinicians, but sometimes I call, like, today was my depression day or my anxiety day, because I saw patients and they were all dealing with depression. But really, just the diagnosis of depression doesn't give you too much, right? And when I really think about how I work with each of those patients, I realize I actually had a plan very differently with each patient. The cause of the depression was different, and the way that we're going to move forward is very different from each patient, even though they were all having the same diagnosis. So that's why it's so important to be clarified and specified in our assessment, how, like Naftali mentioned, how we're going to move forward with the patient. And this is just really an example of an assessment.
Yeah, so when you use that little verbal equation, this is what it would look like filled out. You notice that it's not super duper long, right? Let me see how many sentences. 1, 2, 3 sentences in total. And I'm going to read it out loud just so you have a sense of how condensed it is. But it also gives you a sense, for those of you thinking programmatically, oh, wow, yeah, it takes some training of folks that we hire to be able to do this, to think in this way and to write in this way. So patient with persistent depressive disorder and alcohol use disorder in sustained remission, presenting with recent increase in depressive symptoms and anxiety related to being triggered by recent death of a friend. The patient would benefit from relapse prevention efforts, including improved feeling identification and mindfulness, and coping skills enhancement aimed at increasing tolerance of negative feelings. Patient with good self-awareness and motivation for change, action stage of change. So you see there in those 3 sentences how dense that is, right? We have a really good sense of what the context that patient is facing. There's a recent death of a friend that's triggered this depression and anxiety, but we also have the context of the substance abuse, and so we're going to direct our intervention to do some relapse prevention. And we think that doing some good skill development in the area of being able to manage negative feelings would be a good place to work with, to work towards. And then we are identifying that this person is sufficiently motivated to do this work, right? Really dense, but really, really, really helpful. Now, I'll just make a quick note about that little line below called intervention type. That is a Medicare requirement. So you'll see embedded in the note a bunch of Medicare requirements, because typically Medicare serves as your baseline requirement for your regulatory type stuff. It's not that some payers might request different things, but by and large, if you meet Medicare standards, you're going to be pretty good in general. So the intervention type is a Medicare requirement, and it just means, like, what's the modality being used. So here in this case, we have it labeled as acceptance and commitment therapy. It could be CBT, it could be interpersonal, it could be supportive therapy, could be a bunch of things, but that's just an FYI.
The other thing is that in the intervention type, that's one of the drop downs. Again, that's 1 click or 2 that you can select different interventions instead of typing all the word. Believe it or not, that saves a lot of time. We're going to go to the plan. That's kind of the next step of the note. And this is, again, just the way it will look on the template. And it basically, just going to fill up what are you going to be talking to the patient, what was the homework, or how you're going to move forward with that patient. We recommend that there's not more than 3 or 4 options. We don't want to overwhelm the patient with many instructions or things to do, and it has to be very brief. It also talks about the follow-up. So when are we're gonna invite the patient to come back and see us? If it's 2 weeks after seeing their provider, in a month. Remember that our follow-ups can look very different than traditional specialty care, right? It can be 6 months, it can be a month and a half, or when they see their provider again. So that's gonna be there on the follow-up, and these are drop-downs as well. If they're taking any medications, and specifically psychotropic medications. So we will say there was no change, or if the PCP added something. So that's where it will go. And then just the recommendations. You can see here the examples that we have: reinforce ongoing medication, patient to practice not judgment, identification of negative feeling states as practice in sessions today, and reaching out to friends for support this week. So very concrete, specific things to do for the patient, but we know if they're on the medication or not and when they're gonna follow up.
And again, just a comment on COCM. In the collaborative care model, you'd have a very similar plan outline. It's, you're gonna have, commentary on when follow-up is gonna happen. It could be the next phone check-in, or the next check-in in person, or the next PCP visit. You're gonna have commentary on medication and if there's any changes to their medication plan, or any recommendation, or even just a recommended next review with the consulting psychiatrist. And then you'll have your sort of behavioral goals, essentially.
Then we're going to move to the subjective part. This part, it's that all the information, well, I'm going to pause there with all. I'm going to put quotes and I'll tell you why. That the patient is reporting to you. And when I say all, it's all the information that is relevant to your assessment, right? A lot of the times when we see patients, they give us a lot of information of what's going on in their lives. That doesn't mean that we're going to include everything on this part of the subjective. We're just going to include the information that is relevant to the assessment and the plan that we discuss with the patient, right? So I'm just going to make up another case. So let's say I'm seeing a patient who's dealing with grief because recently lost their partner. And in that conversation is also sharing with me that she fight with a friend and they haven't seen the friend from other reasons, but mainly the plan and what it was important for the patient to talk about in that session, it was about her adjustment and grief after losing their partner. So all the information that she provided to me about the friend and the fight maybe is not relevant to put in the subjective because it has nothing to do with what I work with the patient on that session. So yes, the subjective is everything that the patient told you, but that is relevant to the assessment and whatever you were working with the patient. This is an example. Our idea is that you should not have more than a paragraph with all that information. And a helpful strategy to do that, it's like, for example, if the patient is telling you different symptoms or different circumstances that happen, to, instead of saying, doing different sentence of those statements that the patients provide to you, do it with comma. So patient with, difficulty sleeping, comma, eating less, comma, unmotivated, comma, instead of doing sentence per each of those statements. So that's a way to do it more brief. We're also gonna then talk about if they're progressing in their treatment or not. That's the progress towards prior plan. If it's the first time you're seeing the patient, will be that it doesn't apply. It's the first time that you're seeing it. For how long the problem has been there, and then the severity. And again, these three last sentence, the progress towards plan, the duration of the problem, and the severity are drop downs that you can select. Anything I'm missing?
No, they're there also because there are Medicare requirements. So Medicare requires that you have some assessment of progress, identification of the duration and severity of the problem in support of the diagnosis. And so just by having those, they're clear, it just makes it easy to fulfill those little quick checkbox requirements. They're not they're not terribly helpful from an actual clinical standpoint. They're there to make sure you check those Medicare boxes.
I was going to mention something when you were talking. Well, it'll come to me later.
Well, I'll just mention one thing that we haven't mentioned as much, and this will also overlap some with our billing conversation next time, that your notes, so we generally don't recommend in a pure PCBH model that you have multiple note types. So some, like in specialty therapy, you often have like an intake note.
Oh, yeah.
And then you have your follow-up notes. In PCBH, because we merge intake and follow-up, like in other words, we really take every visit and we do some evaluation and assessment and intervention at that visit, and then the next visit we'll do some evaluation and intervention at that visit. We don't do what specialty mental health does, which is take a long time to do a big intake at the beginning and then, have follow-up. So for that reason, we don't need separate notes. But the subjective will typically get shorter as you go because you do have other notes there that are already documenting some of the aspects that the patient has already discussed. So follow-up subjective sections tend to be a little bit shorter and more to the point than you would have in a first visit.
One thing that just want to highlight that we see when we're reviewing notes of clinicians where we're helping them through the process of integration is that it's common that in the subjective area, they will put some of their own clinical judgments, right? Patient will benefit from, or it will be helpful if patient with. So that's one of the things just to keep in mind, that remember subjective, it's just everything that you're hearing from the patient that is related again with your assessment or what you spoke with the patient on the session. Then we go to the objective part, which this one is actually a section where it's very fast to fill in because it's, it has a lot of drop downs, or at least that's the way we created when in your medical record, which is helpful. So refer by, usually the PCP will kind of integrate automatically if your IT medical record does that. And then they start just how you're seeing the patient, the orientation and cognition, the mood. And again, all those are drop downs, the appearance, harm to self or others. So this is like, for example, if we have a patient with suicidal ideation, where we will put it over there and we will say a little bit more of what's going on with the patient. And of course, you're going to have more information in the subjective and the assessment, but that's very specific, will be in that area of the note. Substance use, again, these are drop downs. Current psychotropic medication used, health risk behaviors, if there are some, and if they complete any screeners. I know for some sites, it's just a norm that as soon as the patient enters the clinic, they will do some screeners. And if that's the case, that can very easily be introduced in the electronic record, but then get embedded on the note. Again, this is something that probably the IT department can help doing that, but it's beneficial because once you open the note, you can see the progress of the scores. As you see here in the example that we have on the square, you can see the results on different dates of that patient.
Yeah, and again, a lot of these are Medicare requirements. They also are important. So they are, many of these fulfill even and again, we'll talk more about this at the next one, an initial intake for Medicare, so a 90791 code. But typically in PCBH, we're just billing a 90832 or 34 type code. Even then, it's really good to have these there and make it easy for your clinicians to use the drop down or pick list to select them and be aware of these important patient parameters.
And lastly, like Naftali was already talking about those billing requirements, who was present in the room, the time that you spend with that patient, and a description of what are the behavioral health services. Again, remember we're talking about a PCBH model here, so important that we provide that information to the patient. And in the time face-to-face, as he was mentioning, due to coding, and then we're gonna go in more depth next month, depending the amount of time that you spend face-to-face with the patient, it's the code that you will use, but you need to specify that over there. If it was below 16 minutes, more than 16 minutes, or over 30 minutes, or whatever that is. Also, in this area, you can also introduce if there was the use of interpreter. That's another area where you can include that.
Yeah, and again, you have a lot of sort of standard Medicare requirements here. The use of interpreter is one of them. For example, obviously the time spent is just standard for any billing. But I want to focus your attention on that last paragraph for a moment, because this is another one of those training issues that you want to be mindful of for folks that you are integrating into an integrated model. And again, this crosses over between PCBH and COCM, where, you know, doing a good informed consent process with the patient is really crucial, I think, to how the service runs in general. And so one of the first things that we work on, the first assignment, in fact, that we work on with a mental health professional when we are working with them on embedding them in a clinic, is to come up with their introduction. And we give them a template. That template includes some of those things that you see there in the note there, and some other things that are important to make that visit work well. And so that's a skill. It may seem like simple, but it's absolutely a skill that the mental health professional needs to have down very, very well, so that they can successfully engage patients effectively in the nature and the style of care that they're providing. It's the same really with a care manager working in a COCM approach. They need to be able to introduce the services. They need to be able to describe, and it's in some ways even more important with COCM, because COCM feels even less familiar to the patient oftentimes. You know, most patients, you know, can wrap their heads around the idea of like, okay, I'm going to meet with you and as a BHC and we're going to work together. But for care management, it involves like, well, we'll maybe calling you. We'll be calling you at certain intervals. We'll have your name in a registry and be following your PHQ-9 scores. It's a little bit more involved, and successfully engaging the patient is important. So we put this here certainly to meet, you know, sort of requirements around informed consent. But behind that has to be really, really good training of your staff to be introducing services effectively. And then connected with that, it's not just how they introduce services, but also mindful of how they're introduced by other members of their team. You've heard us say this before, right? The primary care provider in particular, or sometimes even the medical assistant, need to have the capacity to be able to introduce services effectively in order to engage patients. And again, this affects things like if you're enrolling patients in COCM, you know, a lot of times it depends whether the provider did a good introduction or not, whether the patient's going to say, yeah, I'll meet with that care manager and enroll, or if it's a handoff to a BHC. If the provider doesn't do a good handoff, it really makes it hard for the BHC to engage the patient.
I'm glad you're bringing that up.
I sorry to interrupt, Martha, but
Yeah.
I'm just making the connection here with documentation, because the way we approach documentation is not just, oh, we're just doing this to fulfill requirements and because we got to write notes. Behind this is a tremendous amount of program development and thought around what's going to make this program work really well. And in fact, a nuance of this and the way we train this is that we believe that if you're writing really good notes in this style, that you're also going to be a more effective clinician, right? So we want these notes to help you think really well in the sessions, because we know that this style of work requires efficiency, right? If you're seeing patients for 15 to 30 minutes and you're used to having the luxury of 45 minutes and an hour, you really have to be on point to be very helpful. And so we use documentation as a way to reinforce those good conceptualization skills so that we are helpful in those 15 to 30 minute type encounters.
I was just going to mention that I'm glad that you brought up the importance of the writing of the introduction. Just before this meeting, I was doing a TA work with a new BHC, and she shared the introduction with me, and there was a lot of words that we needed to just modify, because even though she was trying to promote the right message, one word can make a big difference. So if you introduce as I'm the mental health provider, that can look so different and send a completely different message as to what you want the patient to understand. And it's the same as when the providers introduce to you. If they say I have a therapist who's going to be talking to you, can look very different as if I have someone from my team that is going to be working with you in this area that we have been talking about, sleep or insomnia, whatever that is. But it is very important. Just those little details can send a very different message. So the next session that we have here is how to create a routine to maintain a good documentation. And again, I'm going to see if I can do my skills of sharing the PDF document.
Oh, it was just up there.
Oh, are you guys there?
Yeah.
So this is again a document that you all receive in the email, and it's just like a guide for you to have and evaluate how things are going with your documentation process. And also helpful if you have different clinicians, just to kind of review their notes, and it also helps with auditing processes insights.
Yeah, so you may, use it to do some peer review, and it's a form to help the team ensure that their documentation is up to par, which is another good program development tidbit, which is that one thing we often find, even in, or perhaps especially in clinics that are maybe not as integrated, that the notes are all over the place. I mean, you have providers writing in different styles, sometimes completely different templates, different pieces of information in different sections. So you'll often hear a common complaint from primary care providers that mental health notes are not helpful, if they even get them in the first place. But so we, unfortunately, in the mental health world, have a reputation for writing pretty unhelpful notes. Sometimes they're way too long and wordy and non-specific and incorporating way too much information. Sometimes it's just short, full of too much jargon and just not helpful. So using tools like this are a way to make sure that all of your team are producing consistent notes. That, again, sells a service to the primary care team and creates a sense of expectation around what they're going to get from that service, and by extension, what their patients are going to get. That creates confidence for that primary care provider to refer more patients, to make sure to include the integrated health professionals.
One of the things I want to highlight, that even though we're mentioning often that it needs to be concise and brief, that doesn't mean that you're going to remove important pieces of what is happening on the session. That's why we're mentioning you have to be very intentional as to what you're going to put in those notes. And I think when you're starting to learn to write in this new way, this can be very helpful to make sure that you're writing the information that it's relevant to your session, and that again is going to fulfill all the requirements from payers as well. So we're probably not going to go and talk about each of these items, but we're showing this for you guys to kind of get an idea of the important things that you need to take into consideration. If there was, an interpreter in the room, or maybe the diagnosis does not match the information that you're putting on the note, or the other way around. What about the billing code? Like if you spend maybe more time that you put on the note, but you're using a billing code that maybe is representing less of that time. So all those items are important. And as you can see, it's divided through the session. So these are just the general elements, and then it evaluates each section. The subjective, which we talked, remember, it's everything that the patient has reported to you. If you're being inclusive in the language that you're using for the patient. Here are just some elements important to consider. Then it goes to the objective session, which again, if you remember, there were all those drop downs. Medication, questionnaires. Then we move to the assessment section. Here's what we mentioned, that sometimes there can be discrepancy on the notes in which there's information on the assessment, but you don't see that information on the subjective or the other way around. So important to, when you read the note, that you can see a flow. And one of the things that I remember early on my training process, when I was learning to write my notes, I will write them, but then read them out loud to me or one of my colleagues. And that was also helpful to make sure I was adding the correct information and that my note was having a flow. And lastly, the plan section. And we discussed all these things while we were describing the note, the time of the session, follow-up, clear steps of what the patient is gonna be doing, and just comments.
Yeah, so it's a really helpful tool for these peer reviews and audits, and also gives you an idea as you think about building your program. What are some of the key components you have to build in to make this happen, right? Hopefully, we've left you the impression that doing good documentation involves building a good template, but also behind that, also providing some really good training of your staff. And that also involves getting your behavioral health staff on board conceptually with what they're trying to accomplish, because the documentation supports the model of care, right?
Another thing I want to mention is the importance of completing your notes. We have heard some stories in which sometimes there have been months and clinicians haven't finished their notes. And it's just very important that as the clinicians see those patients, ideally, it's that you have just 24 hours to complete that note. Again, having a template, being very effective and intentional of what you put on that note can help you to be, finish your notes on time, even though you have a day in which you saw 10 patients.
Now, one thing we haven't discussed as much, because it's kind of tough to discuss with a bunch of clinics, is how this, what this looks like in an EHR. So Martha and I both use Epic. And so there are certain ways in which Epic handles documentation, and we've found some pretty easy ways. We use, for those of you who do use Epic, we use that template that you saw, is a smart phrase that we embed into Epic. And so we call it up in the note section of a typical documentation flow. What's nice about that is we don't have to, like some systems have created an entire behavioral health note flow, and that's not really that necessary. We just use the same standard medical flow, and we just put the smart phrase into the documentation section of the encounter in our Epic module. Every EHR now has similar stuff like smart phrases and drop downs and smart texts and things like that. So pretty easy to adapt to different strategies. You just want to give some thought to the best and easiest way to implement that. You don't want super complicated documentation strategies. Like the worst we've seen are things where like you develop a bunch of discrete fields and you're just documenting in a bunch of fields, or you're just doing a bunch of checkboxes. That's tough because over time, inevitably, things become irrelevant, or you make changes, or it just gets too limiting. So it's helpful if you have a flexible format. Like a smart phrase is easy because if you decide to make a change in the format of the note or add an element, or a payer asks you to add an element, you can do that. And you can just add the element on your own. You don't need to ask some IT guy to create a whole new field for you or to create a whole new flow for your documentation. You want to keep it as easy as possible.
And one of that case was when COVID hit, that we had to do telemed notes. It's very similar to this note, but it has some variants. So it was easy to just include those things on the note. So the telemed note, when you're doing a visit or a telephone visit, looks slightly different because in the beginning, you want to have the approval that you're asking the patient if you can move forward with the session, if they're in a safe space, if the call get disconnected, that you have a plan, and include those items. But mainly, it's the same note.
That's right. It's a great point, Martha. You just have we have a different template for a smart phrase, for those video consults and phone consults. Then we do these, but it's pretty much the same with like the extra stuff that you need for billing a video visit these days.
Which again, going back to COCM, if your care management are doing those calls, it's a template for, those care management that are just describing that call with the patient and the plan and moving forward and so on.
That's right. And Martha, I apologize. I forgot to tell you that I have to check off a little early because I have to pick up my daughter from school. So I'm going to leave you all in Martha's capable hands here to finish up. My hope is that you have hopefully grasped a very tangible piece of program development today that unfortunately a lot of people skip over this part and they do everything else. And then at the tail end, they might think about the nuts and bolts of doing really good documentation. What we're communicating today is that it shouldn't be an afterthought. It should be something that you have planned. And there's lots of really good tools, including some of the links that I have put in the chat related to how you do some documentation in COCM. So I'm going to log off, but
I'll stay here.
Definitely.
No horse.
Martha, do you still have more things to present, or should we see if people
No.
have questions or thoughts?
Yeah, I just have a few thoughts, but let's hear from the audience.
Okay. Does anybody have questions or thoughts about what was presented today? Anything that you learned that you could do different, that you think might not work?
Hi, this is Sandy from Marshfield, and I'm not a clinician. I'm the manager and director for behavioral health and, informed consent. And I was actually Skyping Jake, one of our clinical psychologists who is embedded into adult primary care. And, for behavioral health, and I know we talked about this under the certification, there's all of these, basically hoops to jump through to make sure that you're in compliance with DHS 35. And so when we talk about informed consent, it also talks about making sure that the patient has your fee list, that the patient has your grievance policy, just to file a grievance. And some of this can take a lot of time, as well as, how much information is disclosed within the organization.
You're cutting out right
do
now.
you have specific to PH?
We just missed the last part of that you cut out. So if you could just repeat that part,
Okay.
Sandra.
Yep, I think, is there do you have a specific consent, treatment consent and informed consent for treatment for PCBH outside of behavioral health?
Yes. So one of the things that we do in some of the sites, it's they have when a new patient comes, they just had all the services that they can get in the clinic, and they agree to sign that, and that's it. That's the only thing they have, and it's embedded the PCBH service that they can receive, right? They don't agree or sign it every time they come. It's just for first time patients, or just like I was mentioning, we were providing some TA for another site just before this presentation. So they're gonna include the PCBH model in their consent form. And from now on, every patient will receive that new one, or they will, sign that one. That's, for that consent. However, on the note, if you remember the last part that we included, is talking about that you mentioned the service to the patient as to how it's going to be served, which is 20 to 30 minutes working as a team and all that stuff. So the consent goes when the patient first see the clinic for the first time, or when you're going to first start your program, but also is that statement on your note as well.
I don't think all of those Chapter 35 requirements, like the grievance procedures and stuff, would be applicable since they're not being seen in a certified behavioral health clinic, right?
You're talking about a regular mental health.
So you're
Right,
talking
it's the
about
treatment.
you're
It's the
talking
treatment
about a
consent
Chapter
for mental
35.
health.
Yeah.
Yep,
Yeah.
yep.
Correct. That all they will not apply. It's different.
Okay.
One of the things that we're gonna discuss on the billing, which will be next month, it's that you want to be how they say it, work smart nor hard in regard to billing. So you don't need, when they're auditing and stuff, you don't want to get all the points in 100. We don't want you to avoid them, but we want to make a negotiation in which you're going to include whatever you need to kind of pass that auditing without getting completely straight A's, if I can say it that way. Because while you do that, then you're losing the capability to serve the patients, right? Because there's, like you're all mentioning, there's so many requirements that you need to include, right? And we will talk more about that in our billing session next month. How to balance that, right? How to balance all the requirements, but also how to keep serving patients.
And are there others on the phone that have more information about the Chapter 35 and what they do with consents?
This is Michelle from Mercy. So there are like she said, there are all kinds of requirements when you're talking about being a certified behavioral health clinic. But like I said, I don't think that those things necessarily would apply when you're working a primary care setting. So you're probably doing informed consent as a best practice, or maybe
Correct.
even as a billing requirement. But all of the rest of the things that are required in the behavioral health clinics are not required in that type of a setting.
That's correct. Thank you, Michelle.
Okay, great.
And we will
Terrific.
definitely go in
Oh,
more depth. No, I was just gonna say we'll definitely go in more depth, like I said, in our billing session next month.
Does anybody
Thank
have any
you.
other questions or comments today?
This is Heather from Theta Care. So just a question about the different smart phrases for telephone and video visits. How do you document a quick, maybe 5 or 10 minute check-in phone call? What's the best way to document that?
Yes, that's a great question. So as Natalie was mentioning, on Epic, we have templates, right? So we actually have one that it says telephone encounter. It's just a telephone call, and it's just who you're talking, the phone, what happened in that, phone call, and any follow-up plan. So it's a paragraph, if I can say that. That's just a regular phone call, like a quick checking. Now, if it was a telemed or a video visit, it's exactly the same. You're just gonna specify in the top if it was a phone or video. but that involves that it was a session, right? It was 30 minutes or over 16 minutes, right? That was a regular session. If it was brief, we call it a telephone encounter. And then at the end, you put it was just 5 minutes. There's no diagnosis, there's no coding. It was just, but it's in the chart of the patient, so you know that was part of what you were doing with the patient.
Okay, so telephone encounter if it's less than 16 minutes, and then the other documentation if it's an actual phone session.
Correct. And again, just on the very top, it's the same note that we showed today, but in the very top, you will just specify it was video or telephone.
Got it. Thank you.
Yeah. And there's a little verbiage that we have in which it just says that we introduce ourselves as a provider with a patient, that they confirm their address, because we want to make sure we're talking to the right patient, right? Either video or phone, and that they agree to have a session in that format. So that's just on the very top.
We just have a few more minutes. Did anybody else have questions? There were good questions.
Can you share the, and you can email it out or share it in the chat, the language that you use on the informed consent for the IBH?
For what, sorry?
The language you're using on the informed consent?
Like for the ones that we give when the patient just comes to the clinic?
Yes.
Yes, I will happily share that with Jen so she can share it with all of you.
Perfect. Anyone else? We have 3 minutes left.
I'm just curious, Jen, do you have a horse next door or not yet?
We don't have a horse yet, but there's about
Okay.
7 people in the field and the mama's laying on her back. So I promised to send a picture of a baby foal being born when I
gosh.
send notes. Okay.
Thank you. I will send that information to you, Jen, so you can share it with everyone. And well, if there's any other questions, thank you so much for joining us today.
Perfect. And everybody, if you have multiple people in the room, send me an email so I can put your name on the attendance sheet. Thanks so much, everybody. We appreciate your participation in the Integrated Behavioral Health Team Training Program. Have a good day.
Thanks, everybody.